Stem cell transplantation still has a role in the treatment of multiple myeloma, as all the studies that have been done, even in the modern era with novel agent induction, have shown that transplantation leads to a prolonged first remission or a progression-free survival advantage. There's literally no study that shows even equality. It's always superior for transplant. And most of us believe that your first remission as a patient is your best remission, and the first remission is the platform off of which subsequent therapies can be built. And if you relapse later, you have access to better and newer therapies at that time. So it's always better not to relapse. So I do use transplantation as part of my initial strategy in myeloma in the vast majority of patients. Most people are transplant eligible, as we are showing here in a large 20,000 patient CIBMTR analysis, which suggests that even patients above the age of 70 can have transplant. And a small subset of patients who get transplanted initially will relapse so long and so late that the transplantation seems a very nice strategy for them again, because you can get them a very long second remission using a transplant-based strategy. So I have patients who have relapsed 5, 8, 10 years later, and they have still cells stored from their first collection. So it's almost as if they never had myeloma in the interim. You re-induce them and retransplant them, but that's a small subset. So transplantation is in the upfront setting, is applicable to the majority of eligible patients, and in the relapsed setting is applicable to a subset of patients. And as long as we don't cure myeloma, or we haven't cured myeloma yet, transplantation will remain a useful strategy.